All right. So starting over, welcome. I'm Lisa Emerson. I'm a Senior Health Policy Advisor for the Division of Financial Regulation. Today is the third RAC meeting, Rules Advisory Committee meeting for DCBS to draft and adopt rules related to primary care provider assignment as directed by Senate Bill 1529. So what we'll be doing today in this meeting is taking a look at the second. Well, first, we're going to offer the opportunity to those who provided written comments after our last second RAC meeting, which was on August 8th, to go over their comments if they'd like to. All those comments have been posted on the Rules Advisory Committee website, the DFR maintains, and I also emailed them out to all those on the RAC meeting list, which includes interested parties. So that's where we'll start. And then next we'll look at an updated draft of the proposed rules, a discussion draft after having considered, the division having considered the comments that we've received so far and additional research that we've done. And then take some time to review this statement of need and fiscal impact document, which accompanies the formal rulemaking process. And then we'll have some opportunity for public comment. And then we will talk about next steps and then adjourn. So with that, I think we had received 3 sets of comments after the second RAC meeting. And I want to offer the opportunity for those that, if they're on the meeting today, with Tom Holt with the Holt Company submitted comments, as well as Providence, Aaron Balls with Providence, and Cambia, that is Marianne, submitted comments. So I'm looking to see who's in attendance today. Just one moment. Okay, let's see. Why don't we start with I thought I saw Tom Holt on here.
Yeah.
Yes.
Tom is there.
Okay. Yeah, Tom, if you'd like to touch on your comments, we welcome you to do so. Anything you'd like to follow up on that?
Thanks. I appreciate that, and had a chance to review the the new revised draft language, and do appreciate the kind of tiering that you've done of what are the steps. I would just like to underscore my comment around allowing the assignment by clinic or clinic system level. I think of, for one of my clients is Zoom Care, and the way people use Zoom Care for primary care is, today they might go to the Salem location, but maybe they live in Tualatin, they'll go to the Tualatin location next week because they work in Salem, and they, so having just clinic system in there, I think would accomplish the goal that you're trying to get to, as well as that clinic level that was talked about in the last meeting. So I think that's true of a lot of kind of systems where I know for myself, I get some care from through one of the large health systems, and I usually get it at one campus. And yesterday I went to a different one so it's that might just be administratively easier.
Thank you, Tom. Appreciate that, the follow-up and explaining, giving us more information to consider. Yeah, we're definitely trying to get there. However, just with the way that the bill is written is so specific to individual provider being the priority for assignment, just weren't quite able to, we didn't want to mess with the definition of primary care provider that's in the law. And so this was an attempt to have that as an option within this. So we'll continue to consider this feedback. Maybe we'll have some other avenues that we can pursue, but again, thank you for going over your comments.
Thanks.
Mm-hmm. And then next, I'd like to offer the opportunity is if someone with Providence I didn't know if I saw Aaron's name or not, but welcome you to have an opportunity to review your comments.
Hi, this is Bo Reitz. I'm a policy analyst with Providence Health Plan. I'll be speaking on behalf of Aaron Balls today.
All right, thank you.
Yeah, so most of the comments in our letter were addressed in the most current draft, of course, allowing the assignment to at the clinic level and the individual level when necessary, and also requiring, or not requiring, but allowing health plans to reach out to specific enrollees where their preferred PCP may be contradictory to their actual utilization. The only comment we have with this new draft is it was added at the very end of Section 4, subsection D, to facilitate access. The insurer may assign the enrollee to a primary care provider group or clinic in lieu of an individual primary care provider. We think to avoid confusion that may only apply to where an enrollee choice is not necessarily in line with their utilization, where that may only apply to them. We'd recommend perhaps that go into a separate subsection to avoid any potential confusion.
All right, thank you, Bo. Appreciate those comments, and we will take another look at that. See if that's something we can accomplish. Again, we've spent some time definitely trying to build in flexibility and understand how primary care delivery system works with, individual providers assignment versus clinic level. And we don't want to, create confusion or overlook something. So appreciate you going over the past comments and then touching on another area that Providence still would like to see some additional work done. So we can talk more about that. Thank you. Let's go next to Cambia. If Marianne is here.
Yeah, hi, this is Antoinette. I will be speaking on behalf of Cambia as I'm a RAC member. Marianne helped me out while I was on vacation.
Okay, thank you.
And I'm sorry, I'm not calling through Teams because I was not unable to. I'm also on the road, so I'm just calling in from the phone. I'm the one with the 0671 number at the end, just in case you were wondering who that is.
Thank you.
So thank you for the latest draft, Lisa. We continue to be concerned that the latest draft does not reflect our concerns with the HIPAA violation by us assigning a member to a PCP where there's like no utilization or there's no existing established relationship with the provider. So we continue to be really concerned with the rules not reflecting that aspect of HIPAA violation. And, we would also like to know whether the DFR has considered this and why it continues not to be addressed. So our comment letter essentially reflects that.
All right, thank you, Antoinette. Yeah, I was going to address that at some point during our discussion that yes, the DFR has considered the HIPAA concern. We've done a lot of research, the policy team internally, but also in consultation with our DOJ attorney, and took a hard look at the HIPAA privacy guidance that is out there on the internet from Health and Human Services. And we do believe that the treatment, payment, and operations FAQs do address this and do allow for patient attribution without a plan may assign a patient to a healthcare provider without consent for treatment, payment, and operations purposes. And I know you can't see it since you're on the phone, but I can share that FAQ. There are a number of FAQs, and we really had to drill down to find this one in particular. And it, again, it's on the Department of Health and Human Services.gov website, HIPAA FAQs for professionals. And one of the FAQs is, can the healthcare providers to whom a patient is referred to for the first time use protected health information? And the answer is yes, the HIPAA privacy rule does not require covered entities to obtain an individual's consent prior to using or disclosing protected health information about him or her for treatment, payment, or healthcare operations. And so I will put the link in the chat so that you have that. And it's on this particular page, it's FAQ number 260. So you can only imagine how, we all know how complex HIPAA is, and there are a lot of good FAQs out there for this. I will put that in the chat.
Okay, great. We look forward to looking at the FAQs in detail. If we have additional concerns, we'll also let you know in writing. Thank you, Lisa.
Okay, you're welcome. Thank you. Yeah, I can get this in the chat here. Paste.
And then since I'm probably not on the chat, I don't know whether I will still receive it because I'm calling from my phone. If
Okay.
you can also email it to me, I would really appreciate it.
I will do that.
Okay, thank you so much.
You're welcome. All right, now that we've reviewed the comments, we can go ahead and let's go ahead and pull up the latest draft of the rule, proposed rule.
Lisa, can I make just one comment while you're pulling up the rules?
Sure.
So it's Amy Grant, United Healthcare. So we also agreed with pretty much everything that everybody's saying about the attribution and the logic. I just want to make clear, and maybe it's, I don't think it's just United Healthcare, but we don't have all clinic levels are willing to accept members at the clinic level. So when we can assign members at the clinic level, but not every provider is contracted to accept at the clinic level. So I just wanted to state that. I didn't know if that was otherwise mentioned by other payers.
That
So
may have been mentioned, but that is helpful to be reiterated because
okay.
We were asking the question internally about, how does that really play out for the consumer, with various health plans. And then
Right.
you've just made a point that United Healthcare can not always do a clinic level assignment. So again, the rules, we're going back to having them be in a hierarchy that the priority is, member choice or enrollee choice to choose an individual primary care provider. And then following the hierarchy, if the opportunity or if the situation occurs that there needs to be that clinic assignment, then that can take place. But first and foremost, it's the patient's choice to choose an individual primary care provider.
Agreed.
In that
Okay,
order.
thank you. Perfect.
Great. All right, before we move on, I'll go ahead and go ahead, Rick, if you would like to make a comment.
Thanks, Lisa. Rick Blackwell, Pacific Source. It sounds like reading 1529 and seeing how specific it is to carriers assigning someone to an individual primary care provider. Is the division confident that we can allow attribution as an option under that statute? And maybe the second question is there any sort of like statutory tallies we're looking at as part of this work? Because it seems like this might lead to some potential changes in the original draft that had passed in 22.
Yeah, thank you for your question. Yeah, we have been discussing this at length internally because the feedback from the RAC and interested parties has been very concerned with the ability for enrollees to be assigned, or mostly from the health plans, to be able to assign to a clinic level and not to an individual necessarily. And we're getting receiving a variety of feedback about how that really plays out in reality with different insurers, different health plans. So because we're using Section 4 to build in this flexibility with involving a clinic or organizational level assignment, it's further down in the hierarchy so that we are complying with the law in the development of these rules to start with the ideal, which is to be assigned an individual provider, PCP. So like I said, we've received feedback from our, when we've talked internally from our DOJ attorney, and we don't want to compromise the definition of primary care provider as it's very clear in the law. And so, but because of this section of the law that requires DCBS to adopt rules prescribing a methodology for assignment, and looking at all the different resources that we've been able to find through the Primary Care Payment Reform Collaborative, as well as the Cost Growth Target Instruction Manual for Reporting, what's built in there is a connection to a clinic level assignment or a organizational level assignment for primary care providers as well. So the opinion currently is that we would not be violating the law building this in, but we're open to additional feedback on that point. This again is trying to build in guidelines or guardrails, but also allow for some flexibility for the health plans in their attribution process or assignment process. That's what I can tell you right now, but feel free to follow up. I don't know if maybe
We
you
have a
can't come
hand.
off mute. Yeah, I think it was.
Go ahead.
He's still on mute. Scott White, I believe, is still on mute.
Oh, yeah, I was just waiting. I
okay.
just wanted to touch base. Thanks, Lisa, on the HIPAA FAQ. I'm looking at that here, number 260, based on the link you sent. And when you look at the full question, this is really specific, and healthcare providers, such as a specialist or a hospital, to whom a patient is referred to the first time. This is talking about a very specific scenario that is not what we're talking about in regards to sharing information, assigning someone a PCP when they have no relationship with that individual. This is talking about referrals. I just wanted to note that this seems like a stretch to apply it to this scenario based on that FAQ. But when you open it up fully, it's specifically talking about specialists or hospitals and referrals from other PCPs that they already have relationships with, not issuer to PCP where we have no data.
Okay, thank you for that clarification, and we can take a closer look at that. I think when it comes down to HIPAA, some other guidance that we've discussed and that we would impart is that these rules are not we would never want them to intend to create a HIPAA violation, a covered entity to make a HIPAA violation. So a couple of ways to approach this. And we have some ideas of how we could, and we've received some suggestions from some of the RAC members on how we could build in some language around HIPAA to protect privacy. But there's two ways to be compliant. You would follow the federal rules for disclosure when a patient hasn't given permission, or obtain the patient's permission to disclose. So basically it goes back to contact your members to facilitate an assignment. I guess that would be we don't necessarily feel that we need to build that into the rule because, bottom line, you can't violate HIPAA. So you really have to make those decisions internally. And so we weren't feeling we needed to put that in rule. So that's kind of my, go ahead.
Yeah, and this is Antoinette from Cambria House. Actually, I think for us, we'll prefer that also be included in the rule in terms of giving us two options to follow so that HIPAA is not violated, so that it's clear. I think that's the way we would want to go as a solution around this issue. I know that we'll be conferring with our legal team later on, and we're happy to also provide other solutions. We did actually provide language changes to the previous draft to avoid that HIPAA violation. So if the DFR is not open to consider that, then I think we would prefer clear language in the rule basically providing solutions how to avoid that HIPAA violation, which is the two that you mentioned.
Okay, thank you, Antoinette. Yeah, we'll discuss that again, after having considered all the feedback we received today. So thank you for making that point. And then I think we'll go to Jennifer. She's got her hand up.
Hi, Jennifer Baker, Cigna Health. And a couple of things I wanted to reiterate our support for what Antoinette and Cambia has commented on in terms of the HIPAA violation. We are very concerned that, if you don't have the language in the rule, that it's not going to be clear. And so we'd really like that clarification in the rule. And I think the language that they proposed was adequate and would meet the expectation. The other issue we have, and I don't know if you've already discussed this or if you feel like any of the rules are permissive on this issue, but for those of us who have Oregon situs-based plans with members who live outside of the state, are we still required to assign an Oregon PCP because of the definition of PCP in the law? How are you going to handle that? Because I can tell you right now, if a member, is on an Oregon fully insured plan, but they live in, a faraway state or even just across the river in Vancouver, they're not going to want an automatic Oregon PCP assignment.
Yeah, I recall that question that we discussed that before. And that language, I don't know that we actually revisited that again. I think it was more of a verbal conversation with one of the other carriers who had originally brought it up. But it needs to be with Oregon, an individual provider licensed in the state. And it doesn't seem like that makes a lot of sense to assign an Oregon provider to someone who doesn't live in the state, and they're not going to be being treated by them. However, the question might still stand. The two aspects may not line up, so you wouldn't be in violation. If the individual isn't living in the state, the enrollee therefore not going to be seeing an Oregon physician, but maybe just on paper would they need to be assigned. I don't believe that we think that makes sense, but I will take that back to the group internally and we'll discuss it again and get something more in writing about that.
Do you think do you think that would need a statutory change? And perhaps we could do a fix in the short session to say for Oregon residents only?
I think that's a good suggestion. We could talk about that. So thank you for bringing that up, Jennifer. Again, I don't have an answer for you right now, but we'll talk about it. Okay, did I get all the hands? Let's see. And I appreciate the question, Amy. Think about dependents or court-ordered coverage. Those people may not be in the state of Oregon. Okay. Yeah, I want to offer the opportunity if there is someone with our internal DFR team that wants to address that, or we can wait and discuss it again so we can have clarity before we talk about it. I think we're missing several people today, so I've made a note of that and we'll see what we need to work out with that.
We have a hand up from Bill.
I see Bill.
Okay.
Yeah, Bill Dwyer. Please go ahead,
hi.
Bill.
Thanks. So my comment just concerns some language that was added in. There was actually an edit was made in the draft, I think, that is the opposite of what the first draft said. And this pertains to a situation where the utilization doesn't match the member selection. I think that there's just a misunderstanding in terms of what that means. And so I thought I would take a moment to explain what that means. I just think this is a misunderstanding here. So when you think about what is patient choice, I mean, what does that even mean? I think what patient choice means is the patient has an opportunity to go and see whatever PCP they want, or to have whatever PCP they want. And I think that the misunderstanding here is that utilization is something different from that. It isn't. So if a patient decides to go to see a PCP a few times, they've made that choice, and that is their choice. And so, unfortunately, the current draft, it goes beyond what is specified and what is intended in the language by saying that the plan is not allowed to do anything when they see inaccurate data. So certainly that, the phrase that we have to prioritize patient choice appears once, but something else that also appears once is that the rules should promote accuracy. And so by putting this rule in there that says we're not allowed to touch anything if there's a discrepancy, I'm not sure how that's promoting the accuracy of the data. And I don't think that that's in the spirit of what was initially intended. And so when you think about just like what is this particular provision trying to solve? Like, what problem are they trying to solve? I mean, can anyone here imagine a situation where a member is sitting there thinking, you know what, I want to go see this PCP, once every couple months, but I definitely don't, I want my plan to think it's some other PCP. So I want to keep that Dr. Jones as my plan PCP, but I'm not going to go there. I'm going to go somewhere else. It's insane. Nobody's sitting there thinking that. And so I guess the nuance I'm trying to describe here is I think what would be better is to explain a nuance between what might be inaccurate data and what might be a patient choice. Certainly, I think a plan should take into account if a member tells them this is my PCP, then the plan ought to put that into their data. But then after that, subsequent to that, if they're then, maybe the member's behavior changes, I think the plan, it should be totally reasonable that the plan would want to keep that up to date. And, it just would seem to be patently in line with the member's behavior that would be corrected. I think if you can recall the last couple of meetings, I mean, there've been a chorus of comments from providers in particular about the desire to keep the data accurate and all the host of downstream problems it causes when the member attribution data is not accurate. And I just think this is a particular case where this current draft oversteps what was intended. There's just no need for that restriction on keeping the data accurate. It draws. I could summarize by saying, so number one, it just draws an incorrect difference between what is patient choice in terms of, is it utilization or is it telling the plan? I mean, those are not two opposite things. Those are the same thing. And then secondly, it is at odds with the intent of keeping the data accurate.
Okay, thank you, Bill. Does anybody else have a comment on that point that Bill's talking about? And could you scroll down to that language, Karen, down to section 4?
Hi, it's Amy Grant again, News with United. So yeah. I agree, and I have another perspective. So in the day and age today where people don't necessarily have a PCP on a plan, they may be reaching out to any provider who can get them in for their moment. So because a provider is able to get me in doesn't necessarily mean that I'd want that provider to be dedicated to me. But I also agree that data integrity is important. We need to make sure that we are getting members to the right people. But it goes back to if a person's putting in a provider on their enrollment form affirmatively, I'm not quite on the same train track as saying, but our claims say you are going to this doctor, so we're going to override that. I just want to say, members need to firmly put something on their history or on their enrollment form. But again, that claims data is going to be the next best thing to say, okay, they didn't give us one, but it needs to be available. So I'd still want to see that claim history or past personal experience in the factor. But I would be concerned about possibly overriding it just because the provider has one. The other part with United is that provider may not be in the same network that the patient might be involved in their plan today. So there might be kind of a claim history conflict with networks and plan coverage. So there could definitely be some scenarios that don't fit completely in line with that, but totally supporting the fact that we're trying to do the best that we can and make sure that members have the right provider out of the gate rather than trying to have to force them change later.
Yeah, then I'll just add, that all seems totally reasonable, and just making the point that I just think that it's unnecessary to have additional restrictions in there when really all the plans are trying to do is do the best we can in making sure that the data is accurate. So please don't handcuff us and take tools out of our toolkit that will allow us to make the data more accurate.
Agreed.
Thank you. Okay, before I go on to the next hand, I'll just want to clarify that on C here, for C, we were trying to, again, keep the hierarchy with priority to the enrollee's choice. But then offer the opportunity, if you're seeing data issues, you can communicate with the enrollee about the opportunity to switch to the provider with predominant claim utilization. So I don't know how necessarily I'm saying that this would be putting up a roadblock to that, to making sure the data is accurate.
The bill doesn't mention predominant claim utilization. It does not appear in the bill. You're just creating it here for the first time. It's just not necessary.
This actually came from language from the Oregon Health Authority through the Primary Care Payment Reform Collaborative, and also the Cost Growth Target Reporting Manual. So I don't believe I think we took that predominant term out of some of the hierarchy steps for attribution, the guidance that's in there. So we welcome, if you want to take a look at that clause and provide some additional wordsmithing and language that for us to consider, we would appreciate that, Bill.
Can you elaborate more on that though, Lisa? This is Jen Baker again with Cigna. I'm confused why you're taking language from other, like the Oregon Health Authority or the Cost Growth Committee, like that. This is separate from that. Why would that be included? Is there statutory authority allowing you to go here then?
Yes, it's the if you look at the bill, the language in the bill, the DCBS is to develop rules for assignment and attribution that agrees or is consistent with the recommendations of the Primary Care Payment Reform Collaborative, which is facilitated by the team over at OHA Health Policy Division, as well as it ties into what the work that the Cost Growth Target Program is doing. And they all have guidance around or recommendations for patient assignment and attribution based on research in that area. So that's those resources I have sent out before, and they are posted.
Have requirements on a patient assignment, do they?
It's guidance. We're providing guidelines.
Right.
And some of it's more restrictive for different purposes, but for this, it was helping us to have alignment to not be inconsistent with those recommendations.
And I agree. I completely agree. We want to be in line, especially with the Cost Growth Committee. My concern here is that we're just overcomplicating what is already a very complex situation and very difficult to implement. So especially consistently across all carriers. So I'm really hoping that you'll reconsider.
All right. Thank you, Jennifer. We'll take another look at it. Yeah, these rules were intended to provide, I guess we use the term guardrails or guidelines, but to also build in the flexibility that insurers and providers need, but also be consistent with the recommendations of the Primary Care Payment Reform Collaborative. Yeah. All right. Thank you for your patience, Omar. Let's go to you.
Sure. Hi, this is Omar Mesquita from Cambia, and I'm an interested party. I think, so I agree with Amy on the same topic. It's on the same topic. I think there are reasons why a member's claims may tell a different story than the words out of their mouth that they've shared with us. And we at Cambia have chosen to trust the member as sort of the golden rule for accuracy of who they believe their PCP to be. And I think maybe the issue, although I agree with Bill, that this does in a way handcuff a plan one way or the other. And so maybe it's just the word must that is the issue, right? Maybe the adjustment here is to say that the insurer must assign the enrollee based on their methodology. That could be either based on who the member has communicated as their PCP or based on the utilization through the claims. And that would allow, you know, us at Cambia to continue to trust the member, right, wrong, or indifferent, and allow other plans to use claims utilization to make that assignment.
Thank you, Omar. Helpful information. And I think we next will go to Erica.
Hi, my name is Erica Hedberg with Moda Health, and I just want to, obviously I'm in agreement with Bill Dwyer from Moda, and I just wanted to add to that, at Moda, we do look at claims data for assigning members, and if they've chosen a provider and we see utilization at a different provider, we will assign them to a different provider. And the reason I think that it's important to allow carriers to be able to do that, if that's their process, is because what we have found is members may select a provider and then they may change it. And it is very difficult to get a member to communicate with us about PCP assignment. So if we are not allowed to update based off of the claims data, then we're just accepting that there's going to be people assigned to providers that they're not actually utilizing and seeing. And also to add on to that, and I'm sure carriers have different methodologies for doing that. I know that we don't just change an assignment based off of one visit to a provider, but we do have a methodology for how we would change an assignment to a different provider.
Thank you, Erica. So I would like to ask the question of you know, mostly the health plans or insurers have been raising concern with this, but if you look at 4B, doesn't that address that if the enrollee does not choose a primary care provider, then the insurers must assign the enrollee to a PCP based on claim utilization information. So that is in the hierarchy. And that's what you were describing, Erica, is what you all do.
Right, but then I think when you get to C, it's pretty much saying that you can't change it based off of utilization, but you can notify the member and let them know that they may want to change it. And that's the concern I have, is because it's very difficult to actually get a member to go in and do that.
Okay, thank you, Erica. And before I go to other hands, I have another follow-up question that might be able to be built into the additional folks that have their hand up or others that have commented. But what about how much? I think we received some statistics from Bill from Moda about the percentage of enrollees that are difficult to attribute based on, you know, not making a choice and not having any claim utilization information. But the percentage is fairly small, and most of the time the enrollees can be assigned. So I'm just thinking that if, you know, still trying to prioritize the enrollee or the patient's choice, and that might get complicated and have to require the insurer to do some additional communication. But are we dealing with a large number of members potentially? It'd be helpful to kind of know how prevalent this circumstance might present itself in for C, because we're still trying to prioritize. It's the enrollee, the member's choice, who's the insured, who's, you know, paying the premium. It's their policy that they can have, you know, and also the bill, the language of prioritizing patient choice or enrollee choice. So please keep that in mind if you care to make any comment on that. But we'll go to Jeanette, who's been waiting.
Hi, I'm Jeanette Simpson from Pacific Source. And I think just there's some considerations to consider with the patient choice. So sometimes a plan may enroll a member for several years, and they may be on a plan where there's no sort of restrictions as far as, you know, notifying PCP changes, like it doesn't change their benefits. There's not necessarily a clear incentive for them from a benefit standpoint to communicate the information. So given that, obviously what they're communicating would be the priority, but as time goes on, we see patterns where people change doctors, and you know, the information isn't being communicated or changed. And so having this process to be able to make those kinds of updates when it's clear that the member is no longer seeing a certain provider would be, I think, pretty important. Otherwise, we could continue to, send information to the wrong provider entity, which kind of goes to the concerns I think that were being raised around HIPAA and other information. So just wanted to highlight that plan design in some cases doesn't really, may not be an incentive to share this information regularly. That helps. So I'm aligned with just if we can kind of make some adjustments to C to allow for changes and not require that communication, that would be ideal.
All right, thank you. Let's go back to Bill. I'm just going to go in order. We've got 6 hands up, so.
Yeah, and Lisa, I can share some additional data with everyone just right now. But let me just say, and it's what Jeanette is saying is right on. Probably she said it better than I can, which is the concern is the old data. So a member picks something a couple of years ago, but it's clearly out of date now. And so we just need the flexibility to be able to draw the distinction between something that no longer applies versus something that happens like right in the instant. Anyway, just in terms of, so you asked about the percent. So we've at MODA, we spent, and at Eastern Oregon CCO, we've spent a lot of time looking at this and what is the accuracy of our data. And I can tell you that, and this is the math works out great on this, the percent of members that we have to randomly assign, just basically guess who their PCP is because we have no idea, is almost exactly the same as the number of times that our assignment is clearly wrong because we can't get a hold of the member to have them switch it. So we see that over and over again, they are going to a PCP that is not their assigned PCP. And we need the ability to change that if we can't get a hold of them. We're talking about thousands of people where the data is wrong. The member's not doing anything, even though we are sending them letters. And, it's just not an ideal situation. The bill talks about, it says in there, we need to prioritize accuracy. Well, the worst thing that you can do to have accurate PCP attribution data is to make us guess who the PCP is. So that is not going to lead to accurate results. And to limit our ability to fix it when we see that it's wrong, that is not going to help accuracy either. Hopefully that's all I'll have to say about this issue. I'll let others chime in now.
Thank you. That helps. Thank you. Let's see. Got Amy's next in line.
My head's just bobbling off my neck, agreeing with Bill and others that, accuracy and the dart on the dartboard is impossible. It's like how many times will members want to change their primary care doctor because we guessed wrong. Best efforts, we're still guessing. I guess from my point would be is that rather than the DFR telling us what order to send things in, I think, Bill, you might have said it earlier, is that we're all just trying to do the right thing. Every carrier probably has a certain sort order or hierarchy that we look at our providers in terms of what's the member's benefit plan. Is it a tiered plan? Is it a kind of some sort of a quality and efficiency kind of plan base? So those types of things are already built in a hierarchy today to try to select the best provider for our members. So having the DFR be a little bit more prescriptive in terms of when we use what information when may not be the best way. Yes, we need to include all of these possible functions and opportunities to identify the best provider for the member using claims data, using our product types of rules that drive what kind of providers are we trying to get the member to maximize their benefits. Those are things that as a payer, we have to consider because ultimately, I want my members to have the best benefit possible. And just sometimes having prescriptive outside entity telling us which order to possibly look at to assign a member may conflict with the benefit and plan rules that we have that we're really trying to do best for our patients and our members.
Thank you, Amy. Let's go to Deborah.
Hi, thank you. Deborah Rumsey with the Children's Health Alliance. And I just wanted to add in from the provider perspective, patient and provider perspective. I think that from the provider perspective, I would like the ability for assignments to be updated based upon utilization. So one of the purposes is to ensure the best care possible for the patient and to ensure that they have access to the provider that to receive services. And if that is the case, we want, and they are clearly showing they're going to a certain provider, depending upon the payment methodology, depending upon, all of the other drivers, if the patient's going to a provider that is not receiving the capitation payment or, other value-based payment incentives, then they're not getting reimbursed for that service. There's incentives and a need for that to match. And I can tell you from our experience with our OHP population where providers are assigned patients, it is very difficult to get a patient to call a health plan to tell them to change the provider assignment because it does not impact them unless they have a different benefit structure related to a different copay amount or a different payment that they have out of pocket to change. Otherwise, it's not worth sitting on hold for 15, 20, 60 minutes to talk to OHA to get a change in provider. I know this isn't just OHA, but any health plan. And I think that's wasted time and resources. So our experience from the provider level, it's difficult to get the patient to call. We're already talking to them and hearing that, no, I don't want to go with you. And these rules don't really allow for that, the health plans to make that correction based upon either what the provider is hearing from the patient or what they're seeing in utilization. So I do think, and I am in agreement with the health plans who are saying we would like that tool of utilization to be a method to be able to assign to a provider. And I guess from the patient perspective, if I don't have any incentive if it doesn't impact how much copay or what my benefit is, I really have no incentive to sit on a phone and call my health plan or even get on a portal to make that change because it doesn't impact me as a patient. So I think that it just doesn't have aligned incentives. And I think by allowing that flexibility, having the suggested hierarchy, patient choice, utilization, and if not, then, X, Y, or Z, I think that helps. But having the musts and the wills is, I think, goes against what the intent of both the value-based payment program is, the intent of the legislation, and others. So hopefully that helps.
That does help. Thank you. Yeah, all this feedback is helpful at, clarifying any areas that we may misunderstand how it really works within the primary care system. Okay, so in order, let's go to Tara Harrison.
Hi, Tara Harrison with Providence. Nice to meet you, Lisa, and everyone else. I've just started over here at Providence as our Government Affairs Director. But really interested in this issue as it so much involves that evolution towards value-based care, where we have payers and providers coming together to coordinate care for a member or a patient, and then also to share in the risk associated, so that ideally that coordination of care and that provision of care is such that the member's quality of life, their health is improving, and that risk shape associated. Situation where member attribution is incorrect, it undermines those efforts to create those value-based care arrangements between payers and providers. So this issue that my colleagues have been talking about, situations arise where maybe what a member has indicated is different from practice, really does affect that ability to have effective value-based care contracts between payers and providers. And we want this law to move us towards those types of relationships rather than creating a roadblock for us.
Thank you, Tara. Appreciate your comments. And welcome to your new position. Let's thank you for your patience, Tony. Let's go to Tony German.
Yeah, thanks everybody. Tony German, family practitioner and representing Oregon Academy of Family Practitioners on the health provider side. I think we're saying a number of similar things that we've commented before, drawing back to the intentions of moving forward in this state to provide value-based care and clarity around that the ideal scenario we're able to do that is have good data. I think we're all in the understanding this health system provides some challenges to that. But again, the intention of this conversation is really just to create better communication and an emphasis that we do have one party connected. So one human being is connected to a provider. Whether it's member, patient, whatever, really us understanding that figuring out how to do that. There are challenges. I think C provides some flexibility. I think that has been eased. I think it is providing some pressure that is hard and difficult, but think that for us to continue to move forward in this state where we're trying to do cost growth control and utilizing value-based care, having a provider know who their panel is and the reality of that is good. I think C really is outlining that discussion with the member or the patient, and that the onus is on whether that's an OHP member or a commercial, that conversation is proceeding. I think the conversation of must, I think, is a good one, and having some flexibility. But I do think that we feel from OHP that this is still a valid approach.
Thank you, Tony. So just to clarify, if you could, I want to make sure I followed, and I certainly can go back and listen to the transcript. But so are you saying that you're supportive, you and your colleagues are supportive of C as written, or would you propose any changes?
I think C as written still is supportive of our efforts here.
Thank you. Okay. So thank you all for your comments on the most current draft of the proposed rules. I just want to make sure we looked at all of them. I know you've received a copy, so I won't probably belabor the point because we've had some good discussion, but you will be given definitely an opportunity to put your verbal comments into written comments if you wish, and propose language for us to consider. We welcome that, of course. So let's look at D, 4D. And I wanted to know, again, how the RAC feels about this section of the proposed rules. We were trying to build in just a little bit of guidance and clarity around if there's no information for the enrollee, their choice or their utilization, the insurer, whether we use must or will or something different, it will be to assign the enrollee to a primary care provider using an example of the criteria that's used, which I received some of this language out of the cost growth target manual. But we just are suggesting, and it's not a limited list, but zip code, like the area where someone lives in proximity to the provider is important. The availability of the provider, age, and other considerations. So wanting to know how we feel about this, that it's a guide rail, it's not all inclusive. Go ahead, Amy.
I appreciate the way this is written because it's an inclusive statement, but it's not an all-inclusive. So I go back to quality metrics and performance measures and those types of things. So I appreciate this being a little bit more free, a little more open to accept other metrics that can feed into that best possible solution for the member. So I, for one, can appreciate this one.
Thank you, Amy. Does anybody else have any question or comments on this section of the draft rules? And the other thing, okay, Jennifer, please go ahead.
Hi, Jennifer Baker again, Cigna. I think that this would be a great place to add language that says, and again, I'm sorry, I didn't hear the previous comment, but something along the lines of if the member doesn't live in the state of Oregon, like you could add language here. So if the insurer has no information or the member lives outside of because then we could apply the zip code to the out-of-state member.
Okay, thank you, Jennifer. That's a good note to take. Because I think that we can build in that flexibility and provide clarity in this section of the rules. So
That would be great. That's really helpful. Thank you.
Okay. Scott, please go ahead.
Hi, Lisa. Scott White from Moda Health again. I just wanted to check the last sentence here. Is this the only scenario of the 4 that would allow issuers to assign at a facility level in lieu of an individual level? Is that an accurate statement? Just want to make sure I understand it.
That is accurate. And I think that was the intent, to not conflict with the definition of primary care provider and to not conflict with the bill, with the law.
Okay, thank you. I just wanted to clarify intent. Thanks.
Let's go to Bill.
Yeah, hi, thanks. And I just want to point out, I think there is a statement in here that does not belong in this section, which is this concept that it enables the enrollee the opportunity to access services. It's just not true. So the fact that a plan might guess who the PCP might be has no bearing whatsoever on a patient's ability to access primary care. What it might do is just create some confusion. You got to keep in mind the most likely scenario here where a member enrolls in a plan, this member just doesn't spontaneously generate on the first day that they enroll in the plan. That member existed before, potentially for years. They probably already have a PCP. The problem is that we just don't know who it is. It's not that they don't have one. And so when you're making us guess, no, you're not helping them access primary care services. What you're doing is you're creating confusion. And so I think, there's just no basis for having that statement in this paragraph.
Thank you, Bill. So otherwise, you're supportive of this paragraph, if that.
No, I think that it's a bad idea. I think it's gonna lead to inaccurate data without bringing any benefit.
Okay, so follow-up question would be, if the bill states that an insured must assign a PCP, if they don't choose one by the 90th day, how can the rules conflict with that by not attributing?
Yeah, I mean, that's a good point. And I think that the answer to that question is the same answer to the question of what do we do about the fact that the primary care rules say that the PCP has to be licensed in Oregon. Well, clearly, whoever wrote this bill, they didn't know everything. And there are some inconsistencies, which why we're all here, is we want to clarify and interpret what was the real intent without sitting here trying to make the rules apply to every single word choice that may be ambiguous or whatever. And that's our job, is to say, okay, well, here's the text, but what do they really mean? And what's really going to be best for Oregon? And so I think that's the answer to your question.
Okay, thank you. All right, let's go to Omar.
Hi, this is Omar Mezquita from Cambia. So on this one, I think I agree with Bill that this just doesn't lead to data accuracy, but the angle for my concern is more back to the HIPAA question, which this remains an issue as long as we haven't confirmed that we can share PHI and PI data with a provider for a member who we are guessing the relationship exists with. And in fact, I think in this case, we're saying that we can't establish a relationship. So we're using things like proximity or the availability of appointments or some sort of age split or some other sort of random criteria to assign the members. So really, until that HIPAA question is addressed, this is really problematic. This whole rule is really problematic. So that's on this one. The other thing I wanted to mention is that some of our value-based contracting and some of our alternative payment models do sort of take into account the ability to attribute or assign a member to a clinic. And this would be a situation where the member patient goes to the clinic, has their PCP there, gets a physical done, something they were able to plan for well ahead of time. A couple months later is sick, needs a more, something near term versus being able to get in with their PCP. She's a different doctor at that clinic. And so in that case, we feel, it's appropriate to be able to attribute the member to that 10. Because we only have one claim with their actual PCP, but we have this one other claim with the doctor who happened to see them on the day that they were sick, we can't establish which one of the two is really the PCP, so to speak, or the actual practitioner that the member would see as their primary care physician. And so I would suggest, or I would appreciate if we could apply the ability to assign at the clinic level across the different rules. That's convenient for Cambia because that's what we currently do and how we currently manage our value-based contracts. But I think it's reasonable that we do it, and perhaps reasonable in how we implement this across the board. And I will say, when we can determine, when we have a preponderance of claims that allows us to say it is this practitioner versus that practitioner, we do that. But there are definitely times where we have ties. And so in that case, what's important to us is that clinic is certainly accountable from our perspective for that member's care, and we're able to make that connection then.
Thank you, Omar. So I have a follow-up for you on, because we were wondering and we're discussing internally how this plays out. So there is in fact circumstances where insurance plan enrollee is only assigned to a clinic and organization. Are they also assigned to a provider in that clinic, and then that provider gets changed as needed? Or is it clearly they are assigned only to the clinic?
No, in the case that we can get all the way to the actual practitioner that we believe to be the primary care physician, then that is the determination that we make. And so when it's at the clinic level, it's really a situation where we can't establish sort of that winner at the practitioner level.
Okay, thank you. Deborah, let's go to you.
Thank you. From the provider perspective, I think that the flexibility of being able to assign at the clinic level and not necessarily at the primary care provider level is preferred because of the scenario that Omar just discussed, where you're a medical home, and so you're serving the patient in the way that best meets the need of the patient. It may or may not be for every visit with your individual PCP. You may have a different a practitioner that might be able to serve your needs for the acute visit, or so that you can get in at the time that makes sense for the patient. So I do see that need for that flexibility. And the other thing is, I hear primary care provider all the time confused with the clinic site. And I hear them interchangeable. And so I know that the rules were written for the individual primary care provider, but I wonder if that was the intent. I think that people confuse that in their minds all the time. And I don't know the conversation around that rule and how it was written, but I've got to believe that they intended that clinic site who's going to take care of them within the medical home and not the individual practitioner. It just creates a lot of challenges and limits a lot of flexibility to be able to serve the patient's need within the medical home. So I think wherever we can and wherever we feel comfortable, I think that we need to allow that flexibility for a primary care provider or their clinic. Thank you.
Yeah, thank you for that additional information. We've definitely been going back and forth on this point, and trying to get clarity for that point, that piece. Let's go to Tony.
Yeah, I think this point is worth emphasizing. I know we've discussed it before, but just some illustrations, I think in certain clinics that I worked in, as far as transitions that occur with provider groups, there is a lot of turnover in some of the staffing with that. And as an approach, I think with a number of different clinics, is their ability to do what we're intending of having outreach for population health and for value-based metrics and global health of that and the holistic approach, is that, in my clinic, I had this last year, half of my staff turnover as far as my providers. And so with that, we as a clinic still maintain the integrity of the population health for that group. I would guess, as far as some of the larger health systems, that is their approach to that. It is a team-based approach as we move to more in healthcare with that. And even in smaller clinic settings, in smaller practices, that's still an approach that is warranted. So again, underlining that the primary care provider is a team-based approach. It would be still ideal to have that delineated who the individual provider is, but don't want to be redundant, but I think this is an important point. I do have questions, just, thinking of this question of the thinking from a provider lens. If I have a patient with an abnormal lab and I need to get a hold of them, I'm going to call them until I figure it out. And it does provide, this is a bit of apples to oranges, but it does have some overlap as far as when a provider has or a member with a plan, right? As far as, clarity of who they're going to see is one question. And I think just grant ourselves that still is a very important question. And I understand that the hurdles and discussions with that, but I think just bringing it back, that the intention is just clarity of who is that human being going to be seen for their care is really what our question is for this effort.
Thank you, Tony. So a follow-up for you as a provider would be, would you ideally want to have an individual PCP assigned to patients in your clinic, even though it is a team-based approach for providing that primary care, but still they're assigned? But if that particular PCP is not available, other practitioners would take care of the patient. So can there be one or the other or both? I mean, because we're trying to, again, not conflict with the definition of primary care provider that's in the bill, which says individual. And we have been discussing, as Deborah mentioned, well, did individual also mean a group of providers, as language was suggested by Providence, or a clinic or an organization? So
yeah, I think as medicine goes there, sorry to interrupt you. I didn't mean.
No, please go ahead, and then we'll go to Deborah.
I think a tiered system is an interesting approach to this, to say that ideally it would be to that individual provider. However, an understanding that if that can't be identified, then the understanding that would give flexibility for a group practice. I appreciate other people's comments on that, though.
Thank you. Deborah, please go ahead.
I think that having that assignment at the individual practitioner level at the health plan side takes away the flexibility of the provider to deliver care in the best way possible. They all have their own mechanisms. They have requirements through the PCPCH standards to assign all of the patients within their practice to a PCP. So it is happening. By putting it in rule that it must be at the individual provider level versus the clinic, it takes away that flexibility of the provider clinic to adapt and adjust based upon the needs as they see them while they're giving them the appropriate care. So I think that we just need to be careful about that, but the mechanisms exist and they're there in the provider clinics to have that patient attached to a specific provider that they will always try to see first. And then if that's not the best way or not available, they get to see somebody else in the practice that has the same EMR, that has all of the history, that might even have been able to talk to the provider the day before about that patient that they're going to see. So I feel like the intent again is the medical home, the clinic site. The term primary care provider has been confused along the way, and you meet that intent by allowing that flexibility.
Thank you. Okay, so we have about 15 minutes, and I really appreciate all of the feedback and comments that we've received today about the rules. I want to open it up for public comment, and because the time is limited, I will consider, I'll go ahead and ask Bill to go ahead and provide any comments you wish to take, but we're going to start opening up for public comment to other interested parties after Bill's comments. Please go ahead, Bill.
Sure, Lisa, thanks. I just had an idea for you, and that is just to say that it is still allowing an individual to pick their individual PCP by saying you've picked their group. So those are totally compatible. If you want to see Dr. Jones, great. You've picked Dr. Jones's group, and that is the same thing. So I think you're on safe ground there by allowing that.
All right, thank you. So I would like to offer the opportunity for other folks that may have comments. Just please raise your hand and we will go from there. Give it a moment for people to think about that. Okay, let's go to Tom.
Yeah, thanks, Lisa. It's great discussion around individual versus the clinic. I think what we're experiencing in this discussion is just a little bit of a gap between words in the bill that passed and what was an actual intention. And when we talk about medical home and consumer choice, people are really, medical home is having all those supports that Deborah ticked off of the common EMR, common protocols, et cetera, et cetera. So I agree with those who said that, let's have both. Sure, ideal world, you might see the same person every time, but that's just not reality of how medicine is organized today. We're a long way from small offices being predominant, and the rules should accommodate that. And if the consumer choice is what prevails, then the consumer should be able to choose the clinic level or system level. And same with when we don't know and you've got to take a guess, it certainly makes a lot more sense to pull it up to that clinic level, because the idea is to get have an avenue for the person to have access and not unintentionally create then downstream a conflict between, well, what's covered as products evolve and choice of provider becomes important for what coverage you're getting. So you want to maximize the consumer's ability to utilize their coverage.
Thank you, Tom. Anyone else? Rick.
Thanks, Lisa. Thought I would just take a moment to note that this was a short session bill, was passed pretty quickly. I think there's probably going to be a lot of questions for which intent is going to be hard to divine. And I think this is one that is probably unprecedented. I don't know if there's any other statutes in other states that we could even look to look at attribution. And we can only really look at the Medicaid side, which is a lot different. So I just think we should all keep working together to try to figure out what works in terms of language, and see what we can do. But like, I feel that I just wanted to note that I feel like you have a very tough assignment here. So let's keep at it.
Thank you, Rick. I appreciate that. Yeah, we've been considering that information as well about when it was passed in short session and gone back and looked at everything and are trying to consider all the information. And there is that piece where there's individual PCP is very much discussed in alignment with clinics and organization at an organization level, especially in a lot of the materials that we've reviewed from other sources about how attribution works. So appreciate those comments. We'll keep working through it. Let's go to Antoinette.
Yeah, hi Lisa. It's Antoinette from Cambia Health. I was told that there was some, or I was reminded of a bulletin that is supposed to be coming out outside of this PCP assignment on some other operational questions that carriers have had with Senate Bill 1529. So we were wondering when that is going to come out. Oh, and there's Sasha. Hi.
It's not a bulletin. It is going to be a memo that is going to come out probably under my signature, and it's routing its way through leadership now.
So probably the
Thank
next
you.
week or so, hopefully. Okay, great. And is that going to be pushed out to this RAC, or is it going to be pushed out through your website? And if you subscribe, you can get it.
These are going to be operational best practices and such that will go out to insurers and probably be posted on our website. I can arrange that. Yeah.
Okay. Is it possible to Lisa to also send it to the RAC members too?
Lisa and I will work on that. Yeah.
Yeah.
Okay.
For
Yeah.
sure.
I'd be happy to do that. Make sure it gets
Thank you.
communicated out. You're welcome. Thank you, Tasha. Thank you, Antoinette. Any other public comments for the good of the order? And okay, so we didn't have time to go over the statement of need and fiscal impact, but I did draft some more answers to the different questions, and I would appreciate your time and taking the opportunity to review it and provide feedback. I'm especially interested in administrative costs that may be borne by insurance plans, small business, healthcare providers. If you'd like to weigh in on that information, that would be helpful to receive so we can finish up drafting that to come up with a final draft. And I think I don't have the agenda in front of me, but I did put a time on the agenda when I would appreciate receiving written feedback. So that I believe is can you put that back up, Karen? I'm sorry, I got too many things on my brain. Okay, October 6th, Friday, October 6th. So we would appreciate any written comments from this, based on what we've talked about in this meeting or any other meetings prior. And let's see. Yeah, with that, just thank you again today. It was a really great meeting. Lots of good questions and comments to consider, and we will think about whether or not we need to schedule another RAC meeting for further discussion. It may depend on if I can get an additional draft done and sent out to the RAC for consideration, maybe even before the comment deadline. That will kind of let us know if we need to have another in-person meeting in another RAC. So, and that would be easy to arrange, but I'll give you enough advance notice about that. So I hope you all have a wonderful day, and thank you again. Feel free to reach out if you have any questions or comments.
Thank you.
Have a nice day.
Thank you, Lisa.
You're welcome.
Thank you.
Thanks so much.